Welcome to AI in Rehabilitation, an evidence-based update, a continuing education course designed for physical therapists, occupational therapists, and nurses. Artificial intelligence is fundamentally reshaping the practice of rehabilitation medicine, introducing transformative capabilities in patient assessment, clinical decision-making, intervention delivery, and outcome prediction that span the entire continuum of care. For physical therapists, occupational therapists, and nurses working across inpatient, outpatient, and home-based settings, these technologies represent both an unprecedented opportunity to enhance clinical effectiveness and a significant professional challenge requiring new competencies, workflows, and ethical frameworks. Understanding the evidence base supporting AI-driven rehabilitation tools is now essential for clinicians who seek to deliver care that reflects the current standard of practice and the evolving expectations of patients, payers, and accreditation bodies. A living systematic mapping review of 240 studies published in the European Journal of Physical and Rehabilitation Medicine confirmed that AI has been tested across all stages of the rehabilitation process, with intervention representing 23.8% of applications, prognosis 17.5% assessment, 16.7% diagnosis, 12.9%, and monitoring 12.5%. The majority of these studies focused on neurological conditions, specifically 57.9%, and orthopedic rehabilitation at 22.7%, with stroke, Parkinson's disease, and amputation emerging as the most commonly studied diagnoses. The breadth of AI tools now available for rehabilitation practice is captured comprehensively in the JAMA Summit report on artificial intelligence, which categorizes AI tools influencing healthcare delivery into distinct functional domains spanning clinical decision support, predictive analytics, workflow automation, and patient-facing applications. These domains map directly onto the daily practice of rehabilitation professionals, from sensor-based gait analysis and robotic-assisted therapy to AI-powered documentation systems and predictive discharge planning. Despite this technological momentum, significant implementation challenges persist that must be honestly confronted if AI integration is to benefit rather than burden clinical practice. Over half of published AI rehabilitation studies lack a comparator group, 50.8% to be precise. External validation has been applied in only 5.8% of studies, and explainability has been incorporated in just 10.2%. 70.8% of AI applications rely on supervised learning with small, single-type datasets, limiting generalizability to diverse patient populations and real-world clinical environments. Furthermore, adoption rates vary substantially across rehabilitation disciplines. 63.3% of physical therapists report no experience with AI applications at work. Occupational therapists face significant institutional barriers to implementation, and only 13.8% of clinicians overall feel that their training adequately prepared them for AI integration. These gaps between technological capability and clinical readiness represent both a challenge and an urgent opportunity for the rehabilitation workforce. This course provides an evidence-based examination of AI adoption in rehabilitation, synthesizing current research across assessment technologies, clinical effectiveness, patient population considerations, discipline-specific applications, workforce readiness, clinical documentation, and implementation strategy. The content draws on systematic reviews, meta-analyses, and randomized controlled trials published predominantly between 2022 and 2025, with an emphasis on quantifiable outcomes and actionable clinical implications. Throughout the course, attention is given to the unique roles and perspectives of physical therapists, occupational therapists, and nurses, and to the ethical, equity, and implementation considerations that must inform responsible AI integration. The course is organized into 8 content modules covering AI-driven assessment technologies, clinical effectiveness of AI interventions, patient population and outcome prediction considerations, discipline-specific technologies, clinician training and adoption, AI-powered documentation, and ethics and implementation strategies. Before we dive into the content, let's review the learning objectives for this course. Upon completion, you will be able to identify validated AI assessment technologies and their appropriate rehabilitation settings. You will be able to compare the effectiveness of AI-assisted rehabilitation interventions versus conventional therapy based on current evidence. You will be able to interpret accuracy metrics and key predictors used in AI models for rehabilitation outcomes. You will be able to distinguish AI adoption patterns and implementation barriers across rehabilitation disciplines. You will be able to apply the 6-domain AI competency framework to rehabilitation professional development. You will be able to evaluate the accuracy and limitations of AI-powered clinical documentation systems in rehabilitation. And finally, you will be able to select ethically sound strategies for equitable AI implementation in rehabilitation practice. Keep these objectives in mind as we move through each module, as all content is designed to build your competency across each of these 7 domains. We now turn to Module 1, AI-driven assessment technologies in rehabilitation. The integration of artificial intelligence into rehabilitation assessment represents one of the most rapidly advancing domains in clinical practice, offering physical therapists, occupational therapists, and nurses access to measurement tools that were previously confined to research laboratories. These technologies, spanning wearable sensors, computer vision systems, and robotic platforms, enable the collection of high-resolution kinematic, kinetic, and physiological data that AI algorithms process into clinically meaningful metrics. This module examines the principal AI-driven assessment modalities, their validation status, and their application across rehabilitation settings. Let's begin with sensor-based assessment modalities. Wearable sensor systems incorporating inertial measurement units or IMUs, surface electromyography, abbreviated SEMG, and electroencephalography or EEG, represent the most widely deployed AI-driven assessment technologies in rehabilitation practice. These devices collect continuous kinematic and kinetic data that machine learning algorithms process to extract metrics such as step length, gait symmetry, joint angles, movement smoothness, and muscle activation patterns. In neurological rehabilitation, particularly post-stroke care, IMU-based systems have been validated for both upper limb and gait analysis, supporting assessment paradigms that extend from specialized inpatient gait laboratories to patients' homes. A systematic review of wearable sensor applications in rehabilitation training confirmed that machine learning algorithms, including support vector machines, random forests, and deep neural networks, achieve high classification accuracies when processing multi-sensor data streams, enabling automated identification of movement quality, compensatory patterns, and functional limitations. Surface electromyography integrated with AI algorithms provides assessment capabilities that complement traditional manual muscle testing by quantifying muscle activation timing, amplitude, and coordination patterns during functional tasks. These systems are particularly valuable for assessing neuromuscular control in patients recovering from stroke, spinal cord injury, and orthopedic surgery, where subtle changes in muscle activation may precede observable functional improvements. The Living Systematic Mapping Review identified SEMG as one of the most frequently integrated sensor modalities in AI rehabilitation research, appearing across studies examining both assessment and intervention applications. The clinical utility of EEG-based brain-computer interfaces represents a particularly noteworthy advancement in sensor-based assessment for neurological populations. These systems capture neural signals that AI algorithms decode to assess motor intention, cognitive engagement, and neuroplastic changes that are not observable through behavioral measures alone. In stroke rehabilitation, EEG-based systems provide objective measures of cortical reorganization during motor recovery, enabling clinicians to distinguish between patients whose functional improvements reflect genuine neuroplastic change and those whose performance gains may be compensatory in nature. For occupational therapists assessing cognitive function in patients with traumatic brain injury or neurodegenerative conditions, EEG-based AI tools offer quantitative metrics of attention, working memory, and executive function that complement traditional neuropsychological screening batteries. The convergence of multiple sensor modalities combining IMU data with SEMG and EEG in integrated assessment platforms represents the next frontier in AI-driven rehabilitation assessment, enabling clinicians to simultaneously evaluate motor, neuromuscular, and cortical dimensions of patient function within a single assessment session. Moving now to computer vision technologies. Computer vision technologies powered by deep learning enable contactless assessment of movement through video analysis, automatically quantifying joint angles, posture, and movement trajectories without requiring specialized hardware beyond a standard camera or smartphone. These approaches are particularly valuable in telerehabilitation and home-based settings, where they provide metrics that correlate with traditional clinical scales, such as the Fugl-Meyer assessment and the functional independence measure. By eliminating the need for patients to wear sensors or visit specialized facilities, computer vision-based assessment dramatically expands the reach of objective movement analysis. AI innovations, including machine learning algorithms, natural language processing, and computer vision, offer rehabilitation professionals advanced tools to improve care quality, facilitating more precise assessments, tailored intervention plans, more efficient treatment delivery, and enhanced outcome evaluation. A scoping review of AI-driven virtual rehabilitation for community-dwelling individuals found that computer vision algorithms, including fuzzy rule-based methods, template matching, and deep neural networks, analyze multimodal data streams to provide real-time feedback to patients and clinicians during home-based exercise programs. These systems can automatically evaluate exercise quality, detect compensatory movements, and adjust difficulty levels without requiring clinician presence, though the evidence base for the clinical effectiveness of home-based computer vision assessment remains emerging and requires further validation through randomized controlled trials. Robotic and exoskeleton-based platforms equipped with embedded sensors and AI-driven control systems offer precise measurement of force, torque, and movement during active and passive tasks, enabling detailed assessment of strength, spasticity, coordination, and motor control in neurorehabilitation. These platforms generate high-density data streams that AI algorithms analyze to quantify motor performance with a precision that exceeds traditional clinical rating scales. The network meta-analysis of AI-assisted rehabilitation for musculoskeletal disorders confirmed that robotic platforms serve dual assessment and intervention functions, with single-joint rehabilitation robots demonstrating particular utility for range of motion assessment and monitoring, achieving a surface under the cumulative ranking curve or SUCRA score of 84.7% for range of motion improvement. A bibliometric analysis of robotics and AI applications in neurorehabilitation, spanning 2003 to 2025, documented the exponential growth of this field, with AI-enhanced robotic systems now capable of adapting assessment protocols in real time based on patient performance data. The convergence of robotics, sensor technology, and artificial intelligence has created assessment platforms that simultaneously measure multiple domains of motor function, including force generation, movement velocity, trajectory accuracy, and inter-joint coordination, providing clinicians with comprehensive motor profiles that inform treatment planning and track recovery trajectories with unprecedented granularity. Let's now examine how these technologies are applied across different rehabilitation settings. In inpatient rehabilitation, AI-driven assessment is most commonly integrated with advanced robotic devices, gait analysis systems, and sensor-based platforms for high-frequency, detailed assessment of motor and cognitive function. A longitudinal observational study at an Australian rehabilitation organisation documented 4,208 uses of advanced technology with 269 patients over 12 months, providing the most comprehensive real-world data on AI-enhanced assessment adoption. Physiotherapists accounted for 65% of users, occupational therapists 33%, and allied health assistants 2%. Inpatient settings showed greater relative use of lower limb robotic devices, 51% versus 41% in outpatient settings, with the relative use of these devices particularly elevated for patients with spinal cord injury at 51%, compared to 24 to 31% for other conditions. The most common AI technologies in inpatient settings include treadmill-based robotic exoskeletons with embedded sensors and AI-driven control systems, advanced multi-sensor gait analysis systems, EEG-based brain-computer interfaces for neurological rehabilitation, and high-frequency sensor-based platforms for detailed motor and cognitive function assessment. Outpatient services represent the dominant setting for advanced technology use, accounting for 94% of all uses in that same longitudinal observational study. Clinicians most commonly use devices for patients with stroke, representing 47% of uses, and demonstrated the greatest variety of devices for patients with stroke and spinal cord injury. Frequently deployed AI technologies in outpatient settings include overground robotic exoskeletons for functional gait assessment and training, upper limb robotic virtual reality devices for fine motor assessment, and gamified exogaming platforms that simultaneously assess and treat functional limitations. The diversity of patient populations encountered in outpatient practice necessitates familiarity with a broader range of AI assessment tools than typically required in inpatient settings. In home-based and community rehabilitation, portable wearable sensors, smartphone-based applications, and AI-driven virtual rehabilitation platforms enable continuous, unobtrusive monitoring of activity and function. These technologies are particularly relevant for patients with chronic conditions requiring long-term monitoring, including post-stroke rehabilitation, Parkinson's disease management, and chronic musculoskeletal conditions. AI algorithms analyze multimodal data streams to provide feedback to both patients and clinicians, though the evidence base for home-based effectiveness remains emerging and several implementation challenges must be addressed. Patients and providers report that easy-to-use technologies with minimal equipment requirements are essential for successful home-based deployment, and that at least some in-person sessions with providers remain necessary to complement remote assessment capabilities. Having reviewed the available AI assessment technologies and their setting-specific applications, we now turn to a critical discussion of clinical integration and the limitations of current assessment technologies. Despite the promising capabilities of AI-driven assessment technologies, rehabilitation professionals must understand their current limitations to use them appropriately. The Living Systematic Mapping Review noted, as we mentioned at the outset, 50.8% of published AI rehabilitation studies lack a comparator group. External validation has been applied in only 5.8% of studies, and explainability has been incorporated in just 10.2%. 70.8% of AI applications rely on supervised learning with small, single-type datasets, limiting generalizability to diverse patient populations and real-world clinical environments. These methodological limitations mean that AI assessment outputs should be interpreted as complementary data that enrich rather than replace traditional clinical assessment approaches. Clinicians should maintain proficiency in conventional assessment methods while developing the competency to critically evaluate AI-generated metrics, understanding when algorithmic outputs align with clinical observations and when discrepancies warrant further investigation. The integration of AI assessment into clinical practice requires a systematic approach that includes several key elements. First, validation of AI tools against established gold standard measures within specific patient populations. Second, establishment of setting-specific normative values for AI-generated metrics. Third, development of clinical decision rules that specify how AI assessment data should be weighted relative to traditional clinical findings. And fourth, ongoing monitoring of AI system performance to detect degradation or bias over time. These four elements form the foundation of responsible AI assessment integration, a theme we will return to throughout this course. This concludes Module 1. In Module 2, we will turn to the clinical effectiveness of AI rehabilitation interventions, examining the strongest available evidence from randomized controlled trials, network meta-analyses, and systematic reviews across both musculoskeletal and neurological populations. Welcome to Module 2, Clinical Effectiveness of AI Rehabilitation Interventions. The clinical effectiveness of AI-assisted rehabilitation interventions has been evaluated through a growing body of randomized controlled trials, network meta-analyses, and systematic reviews spanning musculoskeletal and neurological populations. This evidence base, though still developing, provides clinicians with quantifiable benchmarks for comparing AI-driven approaches against conventional care and for selecting interventions most likely to benefit specific patient populations. This module synthesizes the strongest available evidence, examines safety profiles, and presents optimal dosing parameters to guide clinical decision-making. Let's begin with musculoskeletal rehabilitation effectiveness. The most robust quantitative evidence for AI-assisted musculoskeletal rehabilitation comes from a network meta-analysis of 33 randomized controlled trials comparing 13 distinct AI-assisted strategies. For pain relief, therapeutic exergaming ranked highest with a surface under the cumulative ranking curve, or SUCRA, of 87.6%, followed by robotic exoskeletons at a SUCRA of 86.3%. For functional outcomes, gamified exergaming demonstrated the strongest performance with a SUCRA of 99.6%, with hybrid physical therapy combined with exergaming also showing superior results at a SUCRA of 81.2%. For range of motion improvement, single-joint rehabilitation robots SUCRA of 84.7% and AI feedback motion training SUCRA of 83.7% were most effective. Conventional care and asynchronous telerehabilitation consistently ranked lowest across all outcome domains. These rankings provide clinicians with an evidence-based hierarchy for selecting AI-assisted interventions matched to specific treatment goals. A randomized controlled trial of AI-assisted multimodal exercise telerehabilitation for chronic non-specific low back pain demonstrated that the AI group achieved significantly greater reductions in pain scores compared to conventional video-guided telerehabilitation. The most severe numerical rating scale score decreased by 3 points versus 1.5 points in the control group, persistent at 8-week follow-up. Secondary outcomes including disability, pain catastrophizing, and core muscle thickness also showed significant improvements favoring the AI-assisted group. A separate randomized clinical trial evaluating an AI-based self-management app using case-based reasoning for patients with neck and/or low back pain demonstrated that AI-driven personalization improved engagement and adherence through weekly tailored recommendations for physical activity, exercises, and educational content. The comparative advantages of AI-assisted interventions over conventional approaches become particularly evident in telerehabilitation and scalability contexts. A randomized controlled trial examining AI recognition-based telerehabilitation for patients with hypertension demonstrated significant improvements in exercise capacity, illustrating that AI-driven monitoring and feedback can enhance outcomes in populations requiring long-term cardiovascular rehabilitation management. The AI system's ability to recognize exercise form, count repetitions, and provide real-time corrective feedback through standard consumer devices enabled a level of supervised exercise prescription that would otherwise require continuous clinician presence. For rehabilitation professionals managing increasingly large caseloads across dispersed patient populations, these findings suggest that AI does not simply replicate conventional care at a distance, but potentially creates new therapeutic opportunities through continuous monitoring, adaptive programming, and data-driven progression that conventional approaches cannot practically deliver at scale. Digital care programs supported by AI have demonstrated the capacity to safely scale musculoskeletal care without sacrificing quality. A post-hoc analysis of a prospective cohort study found that increasing the physical therapist-to-patient ratio 2.3-fold with AI support maintained equivalent pain response rates 64% versus 63%. It also maintained equivalent mental health outcomes and high satisfaction scores, with higher completion rates in the AI-supported group at 79.9% versus 70.1%. These findings are particularly relevant for healthcare systems facing workforce shortages and growing demand for musculoskeletal rehabilitation services. Turning now to neurological rehabilitation effectiveness, in neurological populations, AI applications have facilitated tailored therapeutic delivery across stroke, Parkinson's disease, multiple sclerosis, and spinal cord injury. For post-stroke upper limb rehabilitation, a network meta-analysis of 101 randomized controlled trials involving 4,702 subjects found that robot therapy, combined with virtual reality, abbreviated RT plus VR, was the most effective modality for improving distal upper limb function with a SUCRA of 84.8%, proximal function with a SUCRA of 74.1%, and overall upper limb function as measured by the Action Research Arm Test, or ARIT, with a SUCRA of 99.6%. Interactive robotics ranked highest for total Fugl-Meyer assessment for upper extremity FMAUE scores, with a SUCRA of 70.5%. While brain-computer interface technology showed the greatest advantage for improving daily living ability as measured by the modified Barthel Index, with a SUCRA of 73.6%. A separate meta-analysis of 10 studies involving 481 stroke patients comparing AI machine learning approaches to conventional therapy found a statistically significant overall effect favoring AI. The authors concluded that AI is a feasible and safe method that improves upper extremity function compared to conventional therapy. The Neuro-AI Rehab methodology bridges neuropsychological assessment and computational modeling to deliver highly personalized cognitive training sessions using virtual reality simulations with feasibility demonstrated in stroke patients. For chronic pain populations, a randomized comparative effectiveness trial of AI-driven cognitive behavioral therapy demonstrated that at 6 months, 50% of AI group patients reported at least moderate improvements compared to 34% in the therapist-led group, with higher completion rates of 82% versus 57%, and only 30% of the clinician time required. The 2025 Cochrane Review of 190 randomized, controlled trials involving 7,188 participants provides the most comprehensive and methodologically rigorous evidence for virtual reality rehabilitation in stroke. When VR was compared to alternative therapy, results showed it may slightly improve upper limb function, characterized as low-certainty evidence. Balance also showed slight improvement, also low-certainty evidence. The review found that VR probably reduces activity limitation, characterized as moderate certainty evidence. When VR was added to usual care, more substantial benefits were observed. It probably increases upper limb function at moderate certainty and may benefit balance at low certainty. Effects on gait speed showed little to no benefit based on very low certainty evidence, and participation and quality of life outcomes similarly showed minimal effects. A meta-analysis of 27 randomized controlled trials involving 1,156 participants found that hybrid VR combined with conventional therapy interventions significantly improved motor function, with benefits maintained at follow-up. Notably, VR-only interventions showed positive trends, but did not reach statistical significance, suggesting that VR is most effective as an adjunct to, rather than a replacement for conventional rehabilitation approaches. Before we move to dosing parameters, let's discuss the safety profile of AI-driven rehabilitation, which is reassuringly favorable across the available evidence. The systematic review of 28 AI rehabilitation projects identified implementation barriers, including technology literacy, reliability, and user fatigue, but no systematic safety concerns. The meta-analysis of stroke rehabilitation concluded that AI is a feasible and safe method. Regarding robotic exoskeleton safety specifically, a study of the hands-free Atalante exoskeleton involving 40 post-stroke subjects reported 2 serious adverse events: vertigo and dysarthria, both judged unrelated to the device. 4 minor device-related events, including knee pain and skin lacerations, were classified as negligible or minor, and 90% of patients reported satisfaction with the intervention. A multi-center investigation of the ABLE exoskeleton involving 24 patients with spinal cord injury across 242 sessions reported 8 device-related minor adverse events, including pain and skin lesions, with no serious adverse events and good satisfaction ratings. The Cochrane review noted that across 59 studies monitoring adverse events in VR rehabilitation, few adverse events occurred, and those reported were relatively mild. Evidence-based dosing parameters are critical for translating research findings into clinical protocols. Let's review the evidence for optimal dosing across different AI-assisted modalities. For virtual reality rehabilitation of upper limb function after stroke, a meta-analysis of 15 studies involving 1,243 participants identified optimal parameters: a total dose exceeding 15 hours, trial length greater than 4 weeks, and session frequency of more than 4 sessions per week, with approximately 1-hour sessions. For lower limb VR rehabilitation, a meta-analysis of 24 randomized controlled trials found that 20 or more sessions produced significant improvements in balance. The Berg Balance Scale improved by 5.14 points, where the timed up and go test was reduced by 1.98 seconds. For exoskeleton-based therapy for spinal cord injury, a systematic review identified evidence-based dosing recommendations. 60-minute sessions performed 3 times per week for 9 weeks, totaling 27 sessions for general rehabilitation goals, with extended protocols of 12 weeks and 36 sessions recommended for cardiorespiratory rehabilitation. A meta-analysis of 34 randomized controlled trials on lower limb robotic exoskeleton training found that daily training intensities of 45 to 60 minutes and weekly training intensities of 3 or more hours may achieve optimal results, with subacute stroke patients showing significant improvements in motor control, gait parameters, and activities of daily living, while chronic patients showed more limited improvement. For AI-assisted telerehabilitation, the randomized controlled trial for chronic low back pain used 30 to 45 minutes per session, 3 times per week, for 4 weeks, demonstrating significant pain reduction. A multi-center randomized controlled trial of wearable exoskeletons for stroke rehabilitation employed a protocol of 30 minutes of exoskeleton training plus 30 minutes of conventional gait training 5 times per week for 4 weeks, demonstrating significant improvements in lower limb strength compared to conventional therapy alone. Finally, in this module, let's review setting-specific technology considerations to help clinicians match AI interventions to the appropriate care environment. Inpatient settings are most appropriate for treadmill-based exoskeletons, which showed significant superiority for balance with a Berg Balance Scale, and for activities of daily living as measured by the Barthel Index. Robot therapy combined with VR ranked highest for upper limb function in inpatient contexts. Outpatient settings support a broader range of technologies, with overground exoskeletons proving more effective for gait parameters, step length, and cadence and walking independence as measured by the Functional Ambulation Classification. In home-based settings, a Cochrane qualitative evidence synthesis identified key implementation factors. Patients experience home-based services as convenient and less disruptive. Services can encourage patient self-management and empowerment, but privacy and confidentiality issues exist when home life is visible to providers, and at least some in-person sessions remain necessary. AI-guided telehealth exercise has produced comparable outcomes in both home and clinical settings for low back pain. This evidence consistently supports hybrid approaches combining settings for optimal outcomes, as the Cochrane review confirmed that VR added to usual care probably increases upper limb function with an SMD of 0.42 at moderate certainty. We'll now move into Module 3, where we examine patient population and outcome prediction considerations. Welcome to Module 3, Patient Populations, Age Considerations, and Outcome Prediction. Identifying which patient populations are most likely to benefit from AI-driven rehabilitation, understanding how age and comorbidity influence treatment response, and leveraging AI-powered predictive models for clinical decision-making are essential competencies for rehabilitation professionals implementing these technologies. This module examines the evidence for population-specific effectiveness, explores the emerging data on age-stratified outcomes, and reviews the performance of AI models that predict rehabilitation trajectories across neurological and orthopedic conditions. Let's begin with neurological populations, where the evidence base is strongest. Stroke patients represent the most extensively studied and validated population for AI-driven rehabilitation, accounting for the largest proportion of neurological rehabilitation research within the 57.9% of AI studies that focus on neurological conditions. AI applications in stroke rehabilitation demonstrate pooled areas under the receiver operating characteristic curve, or AUCs, of 0.872 for outcome prediction, with machine learning and deep learning techniques combined with IMU sensors effectively analyzing upper limb and functional movement patterns. The evidence spans all care settings. Inpatient robotic and sensor-based platforms provide detailed motor assessment, outpatient AI-enhanced therapy improves functional outcomes, and home-based wearable systems enable continuous monitoring of recovery trajectories. In the longitudinal observational study of advanced technology adoption, stroke patients accounted for 47% of all technology uses, confirming their prominence in real-world clinical practice. Parkinson's disease patients benefit particularly from AI-powered home rehabilitation systems that address the chronic, progressive nature of the condition. A pilot study of an AI-powered home rehabilitation system for Parkinson's disease patients reported a mean system usability scale score of 77 out of 100, exercise adherence of 80%, and significant improvements in clinical and quality of life measures with no adverse events. The Human Empowerment Aging and Disability Program for chronic neurological diseases achieved adherence rates of 90% or greater in clinic and 77% at home, with usability rated as good to excellent. These findings suggest that AI-driven personalized intervention planning and long-term outcome monitoring are well suited to the management of progressive neurological conditions requiring sustained patient engagement. Turning to musculoskeletal populations with quantified benefits, orthopedic patients, particularly those with hip fracture and joint replacement, demonstrate exceptional outcomes with AI-driven assessment and discharge prediction. Random forest models have achieved accuracies of up to 98% in balanced datasets and 90% in real-world unbalanced datasets for predicting home discharge in orthopedic populations, with tree-based ensemble models predicting modified Barthel index scores with a root mean square error of 6.58. Machine learning models for post-acute hip fracture rehabilitation have outperformed linear regression, with the most important predictors being cognitive status as measured by the mini mental state examination, pre-fracture functional scores, and admission functional scores. These findings emphasize that functional and cognitive status at admission, rather than demographic variables alone, drive predictive accuracy in orthopedic populations. Chronic low back pain patients demonstrate significant benefits from AI-assisted interventions, as documented by the randomized controlled trial showing greater pain reductions with AI-assisted multimodal exercise telerehabilitation compared to conventional video-guided approaches. For musculoskeletal disorders broadly, the network meta-analysis confirmed that therapeutic exergaming with a SUCRA of 87.6% and robotic exoskeletons with a SUCRA of 86.3% rank highest for pain relief, while gamified exergaming at a sucra of 99.6% shows superior functional outcomes. Osteoarthritis patients represent 73% of AI-supported interventions in chronic rheumatic diseases, with interventions primarily targeting education and exercise advice, demonstrating high usability, engagement, and adherence, though long-term clinical impact remains uncertain. Now, let's turn to one of the most clinically significant findings in this literature: age-stratified evidence. The literature reveals a critical finding with direct clinical implications. Age is negatively associated with upper limb recovery after conventional rehabilitation but not after robotic rehabilitation, suggesting that AI-driven and robotic interventions may help mitigate age-related disparities in rehabilitation outcomes. A secondary analysis of a multi-center randomized controlled trial involving 190 stroke patients found that age was the only variable independently associated with worse response to conventional treatment, while none of the baseline variables, including age, were significantly associated with response to robotic treatment. The authors proposed possible explanations including enhanced positive attitudes of older patients toward technological training, reduced age-associated fatigue during robotic-assisted exercise, and higher challenge levels unbiased by negative stereotypes about older patients' expectations. A 2025 meta-analysis of 13 randomized controlled trials involving 424 post-stroke patients found that robotic therapy showed a moderate but statistically significant effect over conventional rehabilitation with younger age, and intervention duration exceeding 6 weeks associated with enhanced outcomes. For virtual reality intervention specifically, a meta-analysis of 15 studies involving 1,243 participants found younger age as a significant factor contributing to improved outcomes. In older adults aged 65 years and over with frailty, interactive VR training significantly improved lower limb muscle strength, walking speed, balance, and reduced fall risk. A study of community-dwelling adults over age 65 using a modular hip exoskeleton found clinically significant improvements in balance, gait speed, and endurance, with 2 of 4 participants who were initially below the 1 meter per second fall risk threshold, increasing their gait speed above this threshold after intervention. For pediatric populations, a scoping review of 94 studies found that most AI interventions used robotics 77% and human-machine interaction 54%, but only 1% were tailored to individually reported participation needs, identifying a significant gap in child-centered AI rehabilitation. The presence of comorbidities significantly influences both the selection and expected effectiveness of AI-driven rehabilitation interventions, requiring clinicians to integrate predictive risk models with individualized treatment planning. Prior concussion history, mental health conditions, migraine history, and learning disabilities have been identified as risk factors that predict prolonged recovery trajectories in neurological rehabilitation, and AI algorithms increasingly incorporate these variables into predictive models that guide clinical decision-making. In musculoskeletal populations, cognitive status as measured by the mini mental state examination has emerged as one of the most important predictors in machine learning models for post-acute hip fracture rehabilitation, outperforming demographic variables in predictive accuracy and highlighting the complex interaction between cognitive function and physical rehabilitation outcomes. For patients with multiple comorbidities, AI systems that integrate data from multiple assessment domains, physical function, cognitive performance, psychosocial status, and medication profiles offer the potential for more comprehensive and accurate outcome prediction than single-domain models, though the evidence base for multimodal prediction in complex rehabilitation populations remains limited and requires further development through large-scale, multi-center validation studies. Age-related comorbidities present particular challenges for AI-driven rehabilitation that the evidence base is only beginning to address. Older adults frequently present with combinations of musculoskeletal, neurological, cardiovascular, and cognitive conditions that interact in ways that may confound AI prediction models trained on more homogeneous populations. The finding that interactive VR training significantly improved lower limb muscle strength, walking speed, balance, and reduced fall risk in older adults aged 65 and over with frailty suggests that carefully selected AI-driven interventions can produce meaningful outcomes even in complex geriatric populations. However, The pediatric scoping reviews finding that only 1% of AI interventions were tailored to individually reported participation needs serves as a cautionary reminder that current AI tools may not adequately account for the unique developmental, contextual, and participatory considerations that influence rehabilitation outcomes across the lifespan. Finally, in this module, let's examine AI models for outcome prediction, which represent one of the most clinically impactful applications of artificial intelligence in rehabilitation. AI models for outcome prediction in rehabilitation predominantly employ supervised machine learning algorithms, including random forest, support vector machines, artificial neural networks, gradient boosting, specifically XGBoost, and deep learning architectures. In orthopedic populations, random forest models have achieved accuracies of up to 98% in balanced datasets and 90% in real-world unbalanced datasets for predicting home discharge, with slightly lower performance for neurological patients at 96% and 83% respectively. The clinical utility of these predictive models extends beyond simple outcome forecasting to encompass treatment planning, resource allocation, and patient communication. When a random forest model predicts with 90% accuracy that a particular orthopedic patient will be discharged home, this information allows the rehabilitation team to begin discharge planning earlier, allocate therapy resources toward functional independence goals, and set realistic expectations with the patient and family. Conversely, when predictive models identify patients at high risk for prolonged recovery or institutional discharge, clinicians can proactively implement more intensive intervention protocols, initiate early referrals to social work or case management, and adjust treatment goals to reflect the predicted trajectory. The key principle underlying clinical application of AI prediction models is that they should inform rather than determine clinical decisions, providing one data source among many that clinicians integrate with their professional expertise and knowledge of individual patient circumstances. This concludes Module 3. Module 4 will shift our focus to discipline-specific AI technologies and applications, examining how physical therapists, occupational therapists, and nurses each engage with these technologies within their respective scopes of practice. Welcome to Module 4, Discipline-Specific AI Technologies and Applications. The adoption and application of AI technologies in rehabilitation differ substantially across physical therapy, occupational therapy, and nursing, reflecting each profession's unique scope of practice, clinical priorities, and assessment methodologies. Understanding these discipline-specific patterns is essential for interprofessional teams seeking to optimize technology deployment and for individual clinicians evaluating which AI tools are most relevant to their practice. This module examines the AI technologies most commonly used by each profession and their application across rehabilitation settings. Let's begin with physical therapist technologies. Physical therapists account for the majority of AI technology adoption in rehabilitation settings, representing 65% of advanced technology uses in the longitudinal observational study of real-world clinical practice. The most commonly used AI technologies among physical therapists include wearable sensors and inertial measurement units for gait analysis and movement assessment, robotic exoskeletons for lower limb rehabilitation, particularly gait training body weight support systems, including virtual reality treadmill and overground configurations and surface electromyography integrated with AI algorithms for muscle activity analysis. The Living Systematic Mapping Review confirmed that AI was most frequently integrated with wearable sensors, robotic systems, and digital technologies, especially inertial measurement units, surface EMG, mobile applications, and EEG, reflecting the biomechanical and kinesiological focus of physical therapy practice. For musculoskeletal rehabilitation, the network meta-analysis demonstrated that the AI technologies most relevant to physical therapy practice significantly outperform conventional care across pain, function, and range of motion domains. Specifically, therapeutic exergaming achieved a SUCRA of 87.6% for pain, gamified exergaming achieved a SUCRA of 99.6% for function, single-joint rehabilitation robots achieved a SUCRA of 84.7% for range of motion, and AI feedback motion training achieved a SUCRA of 83.7% for range of motion. In neurological rehabilitation, physical therapists employ robotic therapy combined with virtual reality, which ranked highest for improving upper limb function with an ARAT SUCRA of 99.6%, and interactive robotics, which ranked highest for total FMAUE scores with a SUCRA of 70.5%. The breadth of physical therapist-utilized technologies reflects the profession's dual focus on musculoskeletal and neurological rehabilitation across all care settings. Physical therapists have also been at the forefront of adopting AI-enhanced telerehabilitation platforms that leverage sensor data and machine learning algorithms to guide exercise prescription remotely. The randomized controlled trial of AI-assisted multimodal exercise telerehabilitation for chronic, non-specific low back pain demonstrated that AI-guided platforms can achieve significantly greater pain reductions than conventional video-guided approaches, with the most severe numerical rating scale score decreasing by 3 points versus 1.5 points in the control group. Digital care programs supported by AI have demonstrated the capacity to safely scale musculoskeletal care without sacrificing quality, maintaining equivalent pain response rates when the physical therapist-to-patient ratio was increased 2.3-fold with AI support. These findings highlight the potential for AI to extend the reach of physical therapy services, particularly in settings with workforce shortages or in rural and underserved communities where access to specialist rehabilitation is limited. The integration of AI feedback motion training systems that use computer vision to provide real-time corrective feedback on exercise form represents a particularly promising development for physical therapists managing high caseloads across outpatient and home-based settings. Turning now to occupational therapist technologies. Occupational therapists account for 33% of advanced technology uses in rehabilitation settings and focus primarily on technologies supporting fine motor skills, cognitive function, and activities of daily living. The AI technologies most commonly used by occupational therapists include upper limb robotic virtual reality devices for fine motor skill rehabilitation, virtual reality systems for activities of daily living training, computer vision technologies for contactless assessment of movement and posture, and natural language processing for cognitive rehabilitation and communication therapy. AI innovations, including machine learning algorithms, natural language processing, and computer vision, offer occupational therapists advanced tools to improve care quality, facilitating more precise assessments, tailored intervention plans, more efficient treatment delivery, and enhanced outcome evaluation. The occupational therapy profession faces particular challenges in AI adoption, as it lacks cohesive standards or strategies to address AI's impact on education, clinical reasoning, or client-centered practice, creating a risk of professional marginalization without clear competencies and shared frameworks. Brain-computer interface technology, which showed the greatest advantage among AI modalities for improving daily living ability with a modified Barthel index, SUCRA, of 73.6%, represents a particularly promising area for occupational therapy integration, as it directly targets the functional independence outcomes central to the profession's scope of practice. The development of occupation-specific AI guidelines and the integration of AI competencies into occupational therapy education curricula remain critical priorities for the profession. In cognitive rehabilitation, occupational therapists are increasingly utilizing AI-driven platforms that adapt task difficulty and modality in real time based on patient performance. The Neuro-AI Rehab methodology exemplifies this approach, bridging neuropsychological assessment and computational modeling to deliver highly personalized cognitive training sessions using virtual reality simulations. For patients with acquired brain injury, AI algorithms can analyze patterns in reaction time, error rates, and task completion strategies to identify cognitive domains requiring targeted intervention, enabling occupational therapists to design treatment plans with a precision that traditional paper and pencil assessments cannot match. The scoping review of AI-driven virtual rehabilitation confirmed that computer vision algorithms and natural language processing tools are being integrated into home-based rehabilitation platforms, enabling occupational therapists to monitor patient engagement and exercise quality remotely while maintaining the client-centered, occupation-focused approach that defines the profession. However, only 1% of AI interventions in pediatric rehabilitation were tailored to individually reported participation needs, highlighting the need for occupational therapy leadership in ensuring that AI tools address meaningful functional outcomes rather than purely biomechanical metrics. While nurses are less prominently represented in rehabilitation-specific AI technology research, they utilize AI technologies primarily for care coordination, monitoring, and clinical decision support that directly impact rehabilitation outcomes. AI-enabled alert algorithms and wearable sensors enable nurses to detect subtle signs of patient deterioration and fever significantly earlier than conventional methods, supporting timelier clinical interventions. Specific documented outcomes of AI integration in nursing include several particularly striking examples. A discharge support system reduced 30-day readmissions from 22.2% to 9.4%, a statistically significant reduction. A deterioration algorithm cut time to contact senior staff and time to order tests. And AI-assisted neonatal resuscitation accuracy rose to 94 to 95% versus 55 to 80% with conventional methods. AI systems that automate routine follow-up tasks and generate predictive workload models free nurses from repetitive, non-clinical duties and offer data-driven insights to inform staffing decisions, with documentation quality increasing significantly in AI-assisted workflows. In neurosurgical, gynecological, and orthopedic rehabilitation settings, AI-guided imaging tools and personalized follow-up pathways have been linked to smoother recovery trajectories, streamlined follow-up processes, and high patient satisfaction, with nurses noting that these technologies enhance the precision of assessments without wholly replacing the need for human touch. Predictive analytics systems, AI-powered clinical decision support for medication management and care planning, and remote monitoring platforms integrating wearable sensor data round out the AI toolkit, increasingly available to rehabilitation nurses. The nursing profession's role in AI-driven rehabilitation extends beyond direct technology use to encompass care coordination, patient education, and the integration of AI-generated insights into holistic care planning. Nurses serve as critical intermediaries between AI systems and patients, translating algorithmic outputs into understandable care instructions and ensuring that technology-enhanced care remains person-centered. In inpatient rehabilitation settings, nurses are uniquely positioned to monitor patients' responses to AI-driven interventions across the full 24-hour care cycle, identifying subtle changes in function, mood, and pain that inform the rehabilitation team's treatment decisions. The systematic review and meta-analysis of AI literacy in nursing education found that individual-level awareness stood at 73% and positive attitudes at 71%, suggesting a generally receptive workforce. But the variability in implementation of AI-related skills at 67% to 78% underscores the need for standardized, competency-based training that bridges the gap between theoretical knowledge and practical application in rehabilitation nursing practice. The evidence underscores that optimal outcomes in AI-driven rehabilitation depend on effective interprofessional collaboration, with each discipline contributing unique expertise to the selection, implementation, and clinical application of AI technologies. Physical therapists bring expertise in biomechanical assessment and movement science that informs the calibration and interpretation of sensor-based and robotic AI systems. Occupational therapists contribute essential knowledge about functional performance, cognitive motor integration, and client-centered outcome measurement that ensures AI tools serve meaningful participation goals rather than purely impairment-based metrics. Nurses provide the continuous monitoring perspective and care coordination expertise that enables AI-generated insights to be translated into actionable changes in the overall care plan. The longitudinal observational studies finding that physiotherapists accounted for 65% of technology users and occupational therapists 33% reflects current adoption patterns, but optimal implementation requires that all three professions engage actively with AI tools within their respective scopes of practice, share data and insights across disciplinary boundaries, and collaborate on interpreting and applying AI-generated recommendations to individual patient care. Organizations should structure AI implementation initiatives as interprofessional endeavors, with representation from all rehabilitation disciplines in technology selection committees, training program design, and ongoing quality monitoring activities. Technology selection should be guided by setting-specific evidence. In inpatient settings, which show greater relative use of lower limb robotic devices at 51% versus 41% in outpatient settings, treadmill-based exoskeletons, and robot therapy combined with VR offer the strongest evidence for balance, activities of daily living, and upper limb function outcomes, with the added advantage of direct supervision for safety monitoring. Outpatient settings, which account for 94% of all advanced technology uses, support the broadest range of AI technologies, including overground robotic exoskeletons, upper limb robotic VR devices, and gamified exogaming platforms, with clinicians using the greatest variety of devices for patients with stroke and spinal cord injury. Home-based settings require accessible technologies with minimal equipment requirements, with standard webcam-based systems using pose estimation algorithms capable of providing real-time movement analysis without specialized hardware, and AI-guided telehealth exercise, producing comparable outcomes in both home and clinical settings for conditions such as low back pain. The evidence consistently supports hybrid approaches combining settings for optimal outcomes, as the Cochrane review confirmed that VR added to usual care probably increases upper limb function with an SMD of 0.42 at moderate certainty. This concludes Module 4. Module 5 will address one of the most pressing practical challenges in the field: clinician training, adoption, and workforce readiness for AI integration in rehabilitation. Welcome to Module 5, Clinician Training, Adoption, and Workforce Readiness. The successful integration of AI tools into rehabilitation practice depends not only on technological capability and clinical evidence, but also on the readiness of the workforce to adopt, evaluate, and appropriately use these technologies. Current evidence reveals a significant gap between the availability of AI-driven tools and the capacity of rehabilitation professionals to use them effectively, with adoption rates, knowledge levels, and training needs varying substantially across physical therapy, occupational therapy, and nursing. This module examines adoption patterns, identifies barriers, presents competency frameworks, and reviews evidence-based strategies for building workforce readiness. Let's start with current adoption rates by discipline, beginning with physical therapists. Physical therapists demonstrate the most limited AI adoption among the three rehabilitation professions. A cross-sectional study found that 63.3% of physical therapists reported no experience with AI applications at work, and their knowledge about AI applications in rehabilitation was significantly lower than their general AI knowledge. Key predictors of higher AI knowledge among physical therapists include holding a master's or doctorate degree and non-academic employment. Experience also significantly predicts knowledge levels, as does educational qualification. Qualitative research reveals that while physical therapists recognize AI's potential for aiding decision-making and saving time, they express substantial concerns about patient data privacy, potential loss of patient-practitioner relationships, and ethical concerns regarding over-reliance on AI applications. Among those seeking training, 33% call for structured workshops and 22% identify gaps in foundational AI literacy. Occupational therapists demonstrate a distinct adoption pattern where attitudes serve as the key mediating variable for technology adoption. Higher educational levels are associated with greater AI knowledge, more positive attitudes, and higher engagement in AI-related practices. Critically, while knowledge and practice do not directly predict adoption intentions, both influence intentions indirectly through attitudes, suggesting that educational interventions targeting attitudinal change may be more effective than purely knowledge-based training for this profession. Institutional barriers, particularly insufficient organizational support, and ethical frameworks are perceived as major impediments to implementation. The occupational therapy profession lacks cohesive standards or strategies to address AI's impact on education, clinical reasoning, or client-centered practice, creating risk of marginalization without clear competencies and shared frameworks. Effective AI adoption for occupational therapists necessitates systemic changes including standardized protocols, interdisciplinary training programs, and policy reforms complementing individual mindset shifts. Turning to nurses. Nurses demonstrate relatively higher AI adoption rates and more positive attitudes compared to physical therapists and occupational therapists. A systematic review and meta-analysis of AI literacy and competency in nursing education found individual-level awareness at 73% to 80%, and positive attitudes at 71% with a 95%. However, implementation of AI-related skills remains highly variable at 67% to 78%, especially in low-resource settings. AI-powered simulations yield deeper student engagement and improved case management performance in nursing education. AI-enabled alert algorithms support timelier clinical interventions in practice, and AI systems that automate routine tasks reduce burnout and improve workplace morale. Despite these advantages, nurses' overall knowledge of AI in healthcare remains generally limited, and many express concerns about patient privacy and ethical challenges that represent significant barriers to sustained integration. The Flanders case study confirmed that only 13.8% of clinicians across all disciplines felt their training adequately prepared them for AI integration, indicating a universal preparation gap despite nurses' relatively stronger position. To address these adoption challenges, a consensus-driven competency framework has been developed that identifies 6 essential domains, all rehabilitation professionals must master for effective AI integration. The first domain is basic AI knowledge, the ability to explain what AI is and describe its healthcare applications. The second domain addresses social and ethical implications, requiring professionals to explain how social, economic, and political systems influence AI-based tools and their impact on justice, equity, and ethics. The third domain focuses on AI-enhanced clinical encounters, requiring the ability to carry out clinical encounters that integrate diverse sources of information, including AI-generated data, into patient-centered care plans. The fourth domain emphasizes evidence-based evaluation, requiring critical appraisal of the quality, accuracy, safety, contextual appropriateness, and biases of AI-based tools and their underlying datasets. The fifth domain addresses workflow analysis, requiring clinicians to analyze and adapt to changes in teams, roles, responsibilities, and workflows resulting from AI implementation. The sixth domain promotes practice-based learning and improvement through continuing professional development related to AI tools in healthcare. The barriers preventing adequate AI training for rehabilitation professionals fall into three interconnected categories. Institutional and organizational barriers include insufficient organizational support and funding for AI training, particularly affecting nurses, despite their pivotal role in AI-enabled workflows, as well as the cost and resources required for AI technologies, which were identified as the major barriers among physical therapists. Workflow integration challenges create substantial obstacles, with clinicians reporting difficulties incorporating AI into existing clinical workflows due to time constraints and overburdened schedules. Educational and curricular barriers include the absence of structured, occupation-specific training programs, with traditional healthcare education curricula lacking digital competencies, and a notable shortage of qualified professionals capable of delivering AI education to healthcare workers. Individual and professional barriers encompass limited baseline knowledge, negative attitudes, and misconceptions about AI, including fears of job displacement and lack of trust in AI systems due to concerns about explainability and the perceived opacity of algorithmic decision-making. Emerging evidence supports several effective strategies for building AI readiness among rehabilitation professionals, though the literature in this area remains limited in both volume and methodological rigor. AI-assisted problem-based learning has been shown to significantly improve knowledge retention and AI self-efficacy. A randomized controlled trial of 40 undergraduate physiotherapy students demonstrated that AI problem-based learning using ChatGPT significantly improved knowledge retention at 2 weeks and AI self-efficacy compared to traditional problem-based learning, with no significant increase in internet addiction. The large effect size is noteworthy, suggesting that experiential learning with AI tools may be substantially more effective than didactic instruction for building the practical competencies that rehabilitation professionals need. Simulation-based training that allows clinicians to interact with AI clinical decision support systems using realistic patient scenarios provides an additional evidence-based approach, enabling professionals to develop comfort with AI-augmented workflows in low-risk environments before applying these skills in clinical practice. A blueprint for a 3-course AI education program on human-centered AI for health and well-being has been developed and evaluated at 2 universities for nurses. The evaluation confirmed that proposed courses could be integrated into existing master programs, ranging from full integration in 120 credit programs to limited integration in 60 credit programs. Training programs should be occupation-specific and accredited, with formats matched to professional preferences. Nurses emphasize the need for employer-supported training during work hours, while physicians favor flexible asynchronous formats, and physical therapists require structured workshops. Leveraging local champion senior clinicians with advanced degrees on positive attitudes toward AI can facilitate peer-led training and cultural change, as these individuals demonstrate consistently higher knowledge and more favorable adoption attitudes. The Flanders case study found that 85.07% of healthcare professionals expressed interest in introductory AI courses tailored to healthcare, while 80% sought practical, job-relevant AI skills, indicating strong demand for well-designed training programs. Organizations should establish partnerships among developers, professional societies, and academia with multidisciplinary governance, begin with demonstration projects focused on limited use cases, and implement staged, multimodal training approaches that combine foundational AI literacy with practical clinical application. The evidence reveals a consistent pattern across all 3 rehabilitation professions. Theoretical awareness and positive attitudes toward AI coexist with limited practical experience and inadequate preparation for real-world implementation. This knowledge-to-practice gap manifests differently across disciplines, but shares common root causes, including the rapid pace of AI development, outstripping educational curriculum updates, the absence of standardized competency assessments for AI-related clinical skills, and the disconnect between technology developers and clinical end users in the design and deployment of AI tools. The finding that only 13.8% of clinicians overall felt their training adequately prepared them for AI integration underscores the magnitude of this gap and the urgency of coordinated educational reform. Closing the knowledge-to-practice gap requires a multi-level approach that addresses individual, organizational, and systemic factors simultaneously. At the individual level, rehabilitation professionals should seek opportunities for hands-on experience with AI tools in supervised clinical settings, participate in continuing education programs that address both technical and ethical dimensions of AI use, and cultivate a practice of critical evaluation that applies the same evidence-based reasoning to AI tools that clinicians already apply to conventional interventions. At the organizational level, healthcare institutions should invest in infrastructure that supports AI adoption, create protected time for clinician training, establish mentorship programs pairing AI-experienced clinicians with colleagues developing these competencies, and implement systematic evaluation processes that track both the clinical impact and unintended consequences of AI tool deployment. At the systemic level, professional associations must develop and maintain discipline-specific AI competency standards. Accreditation bodies must incorporate AI literacy requirements into educational program standards, and regulatory agencies must establish clear guidelines for the clinical use of AI tools that protect both patients and practitioners. This concludes Module 5. Module 6 will examine one of the most immediately practical AI applications for rehabilitation professionals: AI-powered clinical documentation, including ambient AI scribes and large language model applications. Welcome to Module 6, AI-powered clinical documentation. AI-powered documentation systems, particularly ambient AI scribes and large language models, represent one of the most immediately practical applications of artificial intelligence for rehabilitation professionals. These tools address a well-documented burden. Documentation consumes a substantial portion of clinicians' time, contributing to burnout, reducing time available for direct patient care, and creating inefficiencies throughout the healthcare delivery system. This module examines the evidence for documentation time savings, quality outcomes, accuracy concerns, and profession-specific applications of AI-powered documentation in rehabilitation practice. The documentation burden in rehabilitation practice is particularly acute because of the complexity and multidimensionality of rehabilitation encounters, which typically involve detailed functional assessments, goal-specific intervention descriptions, patient response monitoring, and progress tracking across multiple domains simultaneously. Unlike brief primary care encounters, a typical rehabilitation session may require documentation of specific exercise parameters, patient tolerance, and response data, functional performance measurements, home program updates, and coordination notes for the interdisciplinary team. AI-powered documentation tools promise to address this burden by capturing the content of clinical encounters through ambient listening and natural language processing, then generating structured clinical notes that clinicians can review and finalize. Understanding the evidence for these tools' effectiveness, limitations, and appropriate integration into rehabilitation workflows is essential for clinicians evaluating whether and how to adopt them in their practice. A mixed method study of 119 allied health professionals in Australian private practice found that use of an AI scribe resulted in significant reductions in time spent writing notes, composing letters, and completing documentation out of hours between baseline and 6 weeks, and between baseline and 3 months, though no additional improvement was observed between 6 weeks and 3 months, suggesting that efficiency gains plateaued after initial adoption. Documentation burden was significantly less at 3 months compared to baseline, and productivity increased by an average of 5.8%. Qualitative findings from interviews revealed 4 themes describing participants' experiences. Using the scribe had a positive impact on therapeutic alliance, and administrative workload trust facilitated the use of the scribe, and allied health professionals appreciated the scribe for different aspects of documentation. A non-randomized clinical trial of AI-powered clinical documentation found that clinicians using the AI tool were substantially more likely to report improvements across all measured electronic health record experience metrics compared to controls. A subsequent study examining AI scribe usage intensity identified a clear dose-response relationship between usage frequency and documentation efficiency gains. Specifically, the highest use quartile, those using the AI scribe for more than 80% of appointments, experienced nearly 6 minutes saved in total electronic health record time per appointment, and nearly 4 minutes saved in note writing time, both of which were statistically significant. However, no usage quartiles showed statistically significant changes in after-hours documentation time, indicating that while AI scribes reduced overall documentation burden, these savings occurred primarily during regular clinic hours rather than eliminating late-night charting. A systematic review and meta-analysis of 23 studies found that AI applications reduced documentation workload and related burnout, indicating a moderate reduction in documentation burden. When clinicians reviewed and edited AI-generated drafts, AI applications reduced documentation time. The quality of notes generated by AI tools was at least comparable to those prepared manually by clinicians, though this finding assumes active clinician oversight rather than passive acceptance of AI outputs. A separate systematic review of 11 studies confirmed that both ChatGPT and ambient AI technologies demonstrated significant potential to improve documentation efficiency, though the quality of AI-generated documentation varied across studies and the heterogeneity of methods used to assess document quality influenced interpretation of results. Despite efficiency gains, significant concerns about the accuracy and reliability of AI-generated documentation persist across the rehabilitation literature. A systematic review of large language model applications in clinical documentation identified several accuracy concerns. Factual inaccuracies and hallucinations were common across studies. Reduced performance in complex cases was consistently observed. Content accuracy varied depending on the complexity of clinical scenarios, and loss of clinical nuance was noted by clinicians reviewing AI-generated notes. A comparative test case using ChatGPT-4 to generate rehabilitation prescriptions and International Classification of Functioning Disability and Health, or ICF codes for a stroke case found that the large language model generated broader and more general prescriptions compared to standard textbook answers, made an error regarding the ICF category, but produced no mistakes in the specific ICF codes assigned, suggesting a tendency toward generalization rather than specificity that may have different implications depending on the complexity of the clinical scenario. Approximately 90 ambient scribe platforms currently exist, representing the leading commercial generative AI product in healthcare. Current limitations include lack of regulatory oversight, existing biases, inconsistent interoperability with electronic health records, and lack of physician and stakeholder buy-in due to insufficient confidence in large language model outputs. An ethical analysis of generative AI-augmented clinical documentation noted that AI-generated documentation may embed biases that can spread across clinical teams relying on previous notes or handoffs, compromising clinical judgment, especially for vulnerable populations such as cognitively impaired or non-English-speaking patients. The lack of algorithmic transparency raises concerns that may complicate the determination of responsibility when documentation errors occur. A survey of 677 rehabilitation providers spanning physical therapy, occupational therapy, and speech-language pathology, along with 270 patients with acquired brain injury, found that both groups reported little experience with AI in daily life or healthcare contexts. Both groups reported concerns regarding AI accuracy and privacy, though most providers expressed interest in AI tools for supporting clinical documentation, while patients with acquired brain injury expressed more hesitancy. Both groups agreed that a patient-directed summary would be helpful for improving the utility of open notes and rated goals, progress, activities, and home exercise programs as the most important note components for patients to understand. These findings suggest that rehabilitation-specific documentation tools should prioritize generating patient-facing summaries of key treatment elements rather than simply automating clinician-to-clinician communication. No studies were identified that directly compare AI-generated documentation accuracy across specific rehabilitation settings, inpatient, outpatient, home-based, or stratified by provider type physical therapists, occupational therapists, nurses representing a significant gap in the evidence base. The Living Systematic Mapping review of 240 AI rehabilitation studies found that documentation was not among the primary AI application areas identified, with the primary areas being intervention at 23.8%. prognosis at 17.5%, assessment at 16.7%, diagnosis at 12.9%, and monitoring at 12.5%. This suggests that clinical documentation remains an underexplored but rapidly emerging domain within AI rehabilitation research. A scoping review protocol registered in 2025 specifically aims to address this gap by examining how AI is used by the allied health workforce to improve patient safety, quality of care, and outcomes, with results expected to provide future insights into profession-specific AI documentation accuracy. The evidence base supports several best practices for rehabilitation professionals, integrating AI-powered documentation into their clinical workflows. Let's review each of these recommendations. First, AI-generated documentation should always be reviewed and edited by the treating clinician before being finalized in the electronic health record. The meta-analytic evidence demonstrating that clinician-reviewed AI drafts achieve moderate reductions in documentation time while maintaining quality equivalent to manually prepared notes applies only when active clinician oversight is maintained. Passive acceptance of AI-generated notes without review introduces risks of factual inaccuracies, loss of clinical nuance, and embedded biases that may propagate through subsequent clinical encounters and handoff communications. Second, rehabilitation professionals should be particularly attentive to the specificity and individualization of AI-generated notes. The tendency toward generalization observed in large language model outputs may result in documentation that fails to capture the nuanced clinical reasoning, patient-specific goal progression, and intervention parameters that characterize high-quality rehabilitation records. Third, clinicians should advocate for AI documentation tools that are designed or customized for rehabilitation practice, as generic medical AI scribes may not adequately capture the functional assessment data, treatment progression parameters, and patient-reported outcome measures that are central to rehabilitation documentation. The survey of 677 rehabilitation providers and 270 patients with acquired brain injury confirmed that goals, progress, activities, and home exercise programs are the most important note components for patients to understand, suggesting that AI documentation tools for rehabilitation should be evaluated on their ability to accurately and accessibly convey these elements. Fourth, organizations implementing AI documentation should establish governance protocols that include regular audits of AI-generated note accuracy, clinician feedback mechanisms, and explicit policies addressing the allocation of responsibility when documentation errors occur. The approximately 90 ambient scribe platforms currently on the market operate with limited regulatory oversight, making institutional governance an essential safeguard against quality erosion and liability exposure. This concludes Module 6. In Module 7, we will examine the ethical, equity, and implementation dimensions of AI in rehabilitation, the framework within which all of the technologies and evidence we have reviewed must ultimately be evaluated. Welcome to Module 7, Ethics, Equity, and Implementation Strategies. The integration of artificial intelligence into rehabilitation practice raises fundamental ethical questions about patient autonomy, privacy, algorithmic fairness, professional accountability, and equitable access that must be addressed alongside clinical effectiveness and workflow considerations. Without deliberate attention to these dimensions, AI deployment risks exacerbating rather than reducing the health disparities that already characterize rehabilitation services. This module examines the ethical landscape, identifies equity concerns, reviews regulatory considerations, and presents actionable implementation frameworks for rehabilitation organizations. The primary ethical concerns surrounding AI in rehabilitation encompass patient autonomy, privacy, algorithmic transparency, and professional accountability. Patient autonomy is challenged when AI systems influence clinical decision-making in ways that patients may not understand or consent to, particularly when algorithms operate as opaque systems whose reasoning cannot be readily explained to patients or clinicians. Privacy concerns are heightened by the volume and sensitivity of data that AI systems collect and process, including continuous biometric monitoring data, movement patterns, cognitive performance metrics, and rehabilitation progress information. The Living Systematic Mapping Review noted that explainability has been incorporated in only 10.2% of AI rehabilitation studies, creating a significant transparency gap that undermines both clinical trust and ethical accountability. The question of professional accountability becomes particularly complex when AI recommendations contribute to clinical decisions that produce adverse outcomes. Regulatory frameworks remain fragmented globally, with variation in standards for cybersecurity, accountability, and innovation readiness across jurisdictions. An integrative review of economic, ethical, and regulatory dimensions concluded that the ethical integration of AI into healthcare demands a delicate balance between embracing innovation and preserving patient rights, trust, and equitable access. Rehabilitation professionals must develop the capacity to critically evaluate AI-generated recommendations rather than defaulting to algorithmic authority, maintaining their role as the ultimate decision-makers in patient care while leveraging AI as a clinical tool. Algorithmic bias stemming from the underrepresentation of marginalized populations in AI training datasets represents one of the most consequential equity risks in AI-driven rehabilitation. When machine learning models are trained predominantly on data from specific demographic groups, their performance may degrade when applied to underrepresented populations, leading to less accurate assessments, inappropriate treatment recommendations, and poorer predicted outcomes for patients who are already disadvantaged by systemic inequities in healthcare access and quality. The current evidence base for AI in rehabilitation reflects this concern. 70.8% of AI applications rely on supervised learning with small, single-type datasets that may not capture the diversity of patients encountered in real-world clinical practice. Health equity considerations in the age of artificial intelligence require explicit attention to the social determinants of health that influence both rehabilitation access and outcomes. Marginalized populations may face compounding disadvantages. They are underrepresented in the datasets that train AI models, less likely to have access to the technologies that AI-driven rehabilitation requires, and more likely to experience the downstream effects of biased algorithms in healthcare settings already characterized by disparities. Strategies for mitigating algorithmic bias include developing diverse training datasets that reflect the demographic composition of target populations, incorporating fairness metrics into model evaluation protocols, engaging affected communities in the design and validation of AI tools, and conducting equity audits of AI systems before and after clinical deployment. Digital divides stemming from disparities in technology access, internet connectivity, and digital literacy compound the equity risks of AI-driven rehabilitation, particularly for home-based interventions in underserved communities. A rapid review of ethical and equity dimensions in telerehabilitation for physiotherapy and occupational therapy identified multiple barriers that disproportionately affect vulnerable populations, including limited broadband access in rural and low-income areas, financial barriers to acquiring necessary devices, and lower levels of digital literacy among older adults and individuals with limited educational attainment. These barriers may effectively exclude the patients who stand to benefit most from AI-enhanced rehabilitation, those with limited access to in-person specialist services from the technologies designed to extend care beyond traditional clinical settings. The collaborative AI paradigm for precision neurorehabilitation envisions systems that create individualized digital profiles and simulate the effects of rehabilitation interventions before real-world implementation, merging empirical evidence with clinical expertise and patient-driven goals. However, realizing this vision equitably requires addressing the infrastructure, literacy, and access barriers that currently prevent universal participation. Implementation strategies must include digital literacy training for patients and caregivers, technology lending programs, multilingual interface design, and hybrid care models that combine AI-enhanced remote monitoring with periodic in-person visits to accommodate varying levels of technology access and comfort. The strategic framework for AI deployment in healthcare delivery, as described in the New England Journal of Medicine, illustrates how AI applications span clinical and operational domains with varying levels of adoption, maturity, and total mission value. Organizations should begin with demonstration projects focused on limited use cases that address clear clinical needs, establish a balance between in-house capabilities and vendor partnerships, and quantify total mission value, including non-financial factors such as quality, safety, and access. The challenges and strategies for wide-scale AI deployment in healthcare organizations emphasize the importance of leadership commitment, stakeholder buy-in, comprehensive change management planning, and continuous evaluation and monitoring throughout the implementation lifecycle. Actionable implementation recommendations from the evidence base include adopting frameworks that emphasize co-design with clinicians and patients, data standardization, real-world performance monitoring, ethical and regulatory integration, and multidisciplinary governance. The AI for Impacts framework provides a structured approach for evaluating the long-term real-world impacts of AI-powered clinician tools, encompassing domains of implementation quality, model performance, adoption, clinical outcomes, total cost of ownership, and sustainability. Clinician training should follow the 6-domain competency framework, with occupation-specific accredited programs that address foundational AI literacy, ethical considerations, and practical workflow integration. Local champions, senior clinicians with advanced degrees and positive attitudes toward AI should be identified and empowered to facilitate cultural change and peer-led training within their organizations. Continuous monitoring, transparent reporting of performance metrics, and mechanisms for clinician feedback are essential for maintaining compliance and trust throughout the implementation process. The evidence clearly demonstrates that equity must be explicitly prioritized through diverse training datasets, community engagement in AI design, strategies to bridge digital divides, and regulatory frameworks that hold AI developers and healthcare organizations accountable for ensuring that AI-driven rehabilitation tools benefit all patients rather than exacerbating existing health disparities. The technical, algorithmic, stakeholder, and societal barriers identified in systematic reviews require coordinated, multi-level interventions that address infrastructure, education, policy, and culture simultaneously, with particular attention to the needs of low-resource settings, where implementation of AI-related skills remains highly variable. For rehabilitation professionals, ethical AI integration is not an abstract policy concern, but a daily clinical practice requirement that manifests in concrete decisions about technology selection, patient communication, and treatment planning. Clinicians must develop the habit of critically evaluating AI-generated recommendations against their clinical expertise and knowledge of individual patient circumstances, recognizing that AI systems are tools to augment rather than replace clinical judgment. The 6-domain competency framework explicitly requires that healthcare professionals be able to carry out clinical encounters that integrate diverse sources of information, including AI-generated data, into patient-centered care plans, while also critically appraising the quality, accuracy, safety, contextual appropriateness, and biases of AI-based tools. This dual requirement, integrating AI insights while maintaining critical oversight, represents the fundamental ethical competency for rehabilitation professionals in the AI era. Informed consent processes must evolve to address AI-driven rehabilitation, ensuring that patients understand when and how AI tools are being used in their assessment, treatment planning, and documentation. The survey of rehabilitation providers and patients with acquired brain injury revealed that patients expressed more hesitancy about AI in healthcare than providers, underscoring the importance of transparent communication about AI's role and limitations. Rehabilitation professionals should explain AI tools in accessible language, describe what data is being collected and how it will be used, clarify the clinician's ongoing role in interpreting and applying AI outputs, and provide patients with meaningful opportunities to ask questions and express preferences about technology use in their care. The collaborative AI paradigm for precision neurorehabilitation envisions systems that merge empirical evidence with clinical expertise and patient-driven goals. But achieving this vision requires that patients are active, informed participants in the process rather than passive recipients of algorithmically determined care pathways. Organizations should establish AI governance committees that include representation from all rehabilitation disciplines, patient advocates, ethicists, and informatics specialists to oversee the selection, implementation, and ongoing evaluation of AI tools. These committees should develop and maintain policies addressing data governance, algorithmic transparency, bias monitoring, clinician training requirements, and patient rights related to AI-driven care. The AI for Impacts framework provides a structured evaluation approach encompassing implementation quality, model performance, adoption, clinical outcomes, total cost of ownership, and sustainability, offering organizations a comprehensive tool for making evidence-based decisions about AI investment and deployment. By embedding ethical considerations into governance structures rather than relying solely on individual clinician judgment, organizations can create systematic safeguards that protect patients and professionals alike as AI technologies continue to evolve and proliferate across rehabilitation practice. This concludes Module 7. We now move into our final module, Module 8, which shifts from the evidence-based to practical application, providing rehabilitation professionals with the foundational skills and frameworks they need to engage effectively and responsibly with AI tools in their daily clinical work. Welcome to our final module, Module 8, Practical AI Literacy for Rehabilitation Professionals. The preceding modules of this course have established a comprehensive evidence base demonstrating that artificial intelligence is reshaping rehabilitation practice across assessment, intervention, outcome prediction, documentation, and clinical decision-making. Yet the evidence also reveals a striking paradox. While AI technologies offer measurable clinical benefits, the professionals best positioned to deploy them remain largely unprepared and frequently skeptical. As we have documented, 63.3% of physical therapists report no experience with AI applications at work. Occupational therapists face significant institutional barriers to implementation, and only 13.8% of clinicians overall feel that their training adequately prepared them for AI integration. This module addresses that gap directly, providing rehabilitation professionals with enduring principles, practical strategies, and foundational competencies for engaging effectively with AI tools, particularly large language models, regardless of how rapidly specific products evolve. The goal is not to transform clinicians into computer scientists, but to equip them with the same critical, informed perspective they bring to any other clinical tool, understanding its capabilities, recognizing its limitations, and applying it within the boundaries of sound professional judgment. The resistance and skepticism that many rehabilitation professionals express toward AI is neither irrational nor unwarranted. Qualitative research confirms that physical therapists hold substantive concerns about patient data privacy, potential erosion of patient-practitioner relationships, and the ethical implications of over-reliance on algorithmic decision-making. Occupational therapists identify institutional barriers and the absence of profession-specific AI frameworks as impediments to meaningful engagement. Nurses express concerns about privacy, ethical challenges, and the gap between theoretical awareness and practical competency. These concerns reflect the same evidence-informed caution that defines responsible clinical practice in every other domain. This module honors that caution while demonstrating that effective AI engagement does not require abandoning professional skepticism, it requires channeling it productively. The principles presented here are designed to remain relevant across changing technological landscapes, grounding clinicians in transferable cognitive strategies rather than platform-specific instructions that will become outdated as AI tools continue to evolve. Effective use of any clinical tool begins with an accurate mental model of how it works. Rehabilitation professionals do not need to understand the mathematics of neural networks any more than they need to understand the electrical engineering of an ultrasound unit. However, they do need a working understanding of what large language models are, what they do well, what they do poorly, and why, because these characteristics directly determine how AI output should be interpreted and applied in clinical contexts. Large language models are computational systems trained on vast quantities of text data to predict the most probable next sequence of words given a particular input. They accomplish this through pattern recognition at an extraordinary scale, identifying statistical relationships among words, phrases, concepts, and structures across billions of documents. This training process produces systems capable of generating fluent, contextually appropriate text across an enormous range of topics and tasks. Importantly, however, these systems do not possess understanding in the way that human clinicians understand their patients. They do not have clinical experience. They have never observed a patient, and they do not reason from first principles in the way a clinician synthesizes biomechanical knowledge, patient history, and clinical observation. What they offer instead is a different and complementary form of capability, the ability to rapidly synthesize, organize, structure, and transform information drawn from the patterns embedded in their training data. This distinction carries direct clinical implications. Large language models excel at tasks that involve organizing existing knowledge into coherent structures, generating drafts that clinicians can refine, summarizing lengthy documents, identifying patterns in structured data when appropriately prompted, translating content between formats such as converting clinical notes into patient-friendly language, and providing frameworks for thinking about complex problems. They perform less reliably on tasks requiring real-time factual accuracy, nuanced clinical judgment about individual patients, mathematical calculations, interpretation of current research they were not trained on, and any situation requiring the integration of sensory clinical data, such as the resistance felt during a manual muscle test or the subtle gait deviation observed during ambulation. The Living Systematic Mapping Review's finding that explainability has been incorporated in only 10.2% of AI rehabilitation studies underscores a broader truth about AI systems. Their outputs represent probabilistic predictions rather than deterministic conclusions, and clinicians who understand this distinction are better equipped to use these tools appropriately. One of the most clinically significant characteristics of large language models is their tendency to generate plausible-sounding but factually incorrect information, commonly referred to as a hallucination. This occurs because the model is optimized to produce coherent, contextually appropriate text rather than to verify factual accuracy. In rehabilitation contexts, this means that a large language model may generate a citation that does not exist, attribute a clinical guideline to the wrong professional organization, or present outdated treatment parameters as current best practice. The implication for clinicians is clear and enduring. AI-generated content requires verification through the same evidence-based practice skills that rehabilitation professionals already possess. No AI output should be accepted uncritically any more than a clinician would accept a colleague's recommendation without understanding the reasoning and evidence behind it. The quality of output from any large language model is fundamentally determined by the quality, specificity, and structure of the input it receives. This principle, often summarized as the relationship between input quality and output quality, is the single most important concept for rehabilitation professionals beginning to work with AI tools. A vague, poorly structured request will produce a vague, generic response. A specific, well-contextualized request will produce a targeted, useful response. Let's review the foundational principles for effective AI interaction that apply regardless of which specific platform a clinician uses. The first principle is to provide context and specify your role. Large language models generate more relevant and accurate outputs when they understand the professional context in which their response will be used. A physical therapist requesting information about shoulder rehabilitation will receive substantially different and more useful responses when the request establishes that the user is a licensed clinician working with a specific patient population than when the same question is posed without context. Establishing context involves communicating relevant background information such as clinical setting, patient population, professional discipline, and the intended use of the output. For example, informing the AI that the user is an occupational therapist in an acute inpatient rehabilitation unit working with a patient population recovering from traumatic brain injury will orient the model's responses toward the appropriate level of clinical sophistication, terminology, and functional outcome focus. This practice of contextual framing is analogous to the way clinicians communicate with consulting specialists. The more relevant information shared upfront, the more targeted and useful the response. The second principle is to be specific about desired output format and scope. Rehabilitation professionals should specify not only what information they want, but also how they want it organized, how detailed it should be, and what format would be most useful. A request for information about virtual reality in stroke rehabilitation will produce a fundamentally different response when the clinician specifies that they need a concise summary of dosing parameters suitable for treatment planning compared to when they request a comprehensive literature overview. Specifying the desired length, structure, level of detail, and intended audience transforms a generic information request into a targeted professional tool. Clinicians should consider whether they need a brief summary or an in-depth analysis, whether the output should be organized by topic, chronologically, or by evidence strength, whether technical terminology is appropriate or whether patient-accessible language is needed, and what specific elements must be included or excluded. This specificity mirrors the precision that rehabilitation professionals already apply in their clinical documentation, goal setting, and intervention planning. It is simply directed toward a different tool. Continuing with our foundational principles for effective AI interaction, the third principle is to decompose complex tasks into sequential steps. Complex clinical tasks are more effectively addressed through a series of focused interactions rather than a single comprehensive request. Just as a physical therapist would not attempt to assess strength, range of motion, balance, gait, and functional mobility in a single, undifferentiated evaluation block, clinicians should break complex AI-assisted tasks into logical sequential steps. For instance, if a nurse needs to develop a patient education handout about a new robotic rehabilitation program, the process might begin with requesting an outline of key topics to cover, followed by developing each section individually, then requesting a review for health literacy level, and finally asking for the content to be formatted for the intended distribution method. This sequential approach allows the clinician to evaluate and refine each component before proceeding, maintaining quality control throughout the process, and preventing the compounding of errors that can occur when AI is asked to perform multiple complex tasks simultaneously. The fourth principle is to use iterative refinement rather than starting over. One of the most powerful yet underutilized features of conversational AI interaction is the ability to iteratively refine outputs through ongoing dialogue. When an initial AI response is partially useful but requires modification, clinicians should build on that response by providing specific feedback about what works and what needs to change rather than abandoning the interaction and starting from scratch. This iterative approach mirrors the clinical reasoning process. An initial assessment informs a treatment plan, patient response data refine the intervention, and ongoing reassessment drives continuous adjustment. The same feedback loop applies to AI interaction. Initial outputs serve as working drafts that the clinician shapes through targeted feedback, correction, and elaboration until the final product meets professional standards. Clinicians who adopt this iterative mindset will find that their AI interactions become progressively more efficient as they develop skill in providing the specific, constructive feedback that drives rapid improvement in output quality. The fifth principle is to establish constraints and boundaries. Effective AI interaction requires explicitly stating what the output should not include, as well as what it should. In rehabilitation practice, this might involve specifying that responses should rely only on evidence from randomized controlled trials, that recommendations should be limited to interventions available in outpatient settings, that content should not include pharmacological interventions outside the clinician's scope of practice, or that patient education materials should avoid medical jargon above a specified reading level. Setting these boundaries upfront prevents the need for extensive post-generation editing and ensures that AI outputs align with professional scope, institutional policies, and patient needs. Constraints function as clinical guardrails that keep AI outputs within the bounds of appropriate professional use. Now let's turn to clinical applications of AI tools across rehabilitation practice. Understanding these practical applications helps clinicians move from abstract awareness to concrete engagement. The applications we will discuss focus on areas where large language models and related AI tools can augment clinical efficiency and effectiveness without requiring specialized technical infrastructure or significant financial investment. For clinical documentation support, as established in Module 6, documentation consumes a disproportionate amount of rehabilitation clinicians' time and contributes to professional burnout. AI tools can assist with multiple dimensions of the documentation process. Clinicians can use large language models to generate draft clinical notes from structured key points, translate clinical documentation into patient-friendly summaries, create template frameworks for common encounter types, and review existing documentation for completeness and consistency. The meta-analytic evidence confirming that AI applications reduce documentation workload with a standardized mean difference of negative 0.71 supports the integration of these tools into clinical workflows. However, as the evidence in Module 6 also demonstrates, AI-generated documentation requires active clinician review to prevent factual inaccuracies, loss of clinical nuance, and the propagation of embedded biases. The clinician's role shifts from primary author to editor and quality assurance reviewer, a role that requires maintaining the same clinical expertise and documentation standards that have always defined professional practice, while gaining efficiency in the mechanical aspects of note production. Creating individualized patient education materials represents one of the most immediately accessible and low-risk applications of AI for rehabilitation professionals. Clinicians can use large language models to draft home exercise program instructions tailored to specific patient populations, generate educational content about diagnoses and treatment approaches at appropriate health literacy levels, translate complex clinical concepts into accessible language for patients and caregivers, and create frequently asked questions documents for common clinical scenarios. The survey of rehabilitation providers and patients with acquired brain injury confirmed that goals, progress, activities, and home exercise programs are the most important note components for patients to understand, validating the clinical relevance of AI-assisted patient communication. When generating patient education content, clinicians should review all materials for clinical accuracy, ensure that language complexity matches the target audience, and verify that recommendations align with the patient's specific treatment plan rather than generic guidance. Rehabilitation professionals can also use AI tools to support evidence-based practice by requesting structured summaries of research on specific clinical questions, generating comparisons between intervention approaches for particular patient populations, identifying potential outcome measures for clinical scenarios, and organizing complex clinical information into decision-making frameworks. Clinicians should treat AI-generated evidence summaries as starting points for investigation rather than definitive answers, verifying key claims and citations against primary sources before applying them to clinical decision-making. Beyond direct clinical applications, AI tools can enhance rehabilitation professionals' efficiency in administrative tasks, including drafting professional correspondence and referral letters, organizing and summarizing meeting notes, creating structured templates for quality improvement initiatives, generating frameworks for program development proposals, and assisting with scheduling optimization and caseload management documentation. The finding from the digital care program analysis that increasing the physical therapist-to-patient ratio 2.3-fold with AI support maintained equivalent outcomes suggests that AI-enhanced administrative efficiency can translate into meaningful capacity gains without compromising care quality. The most essential skill for rehabilitation professionals working with AI is not technical proficiency, but critical evaluation, the ability to assess AI-generated content with the same rigor applied to any other source of clinical information. This skill draws directly on the evidence-based practice competencies that rehabilitation professionals have developed throughout their training and careers, requiring only a reorientation of these existing capabilities toward a new type of information source. Every factual claim generated by a large language model should be treated as a hypothesis requiring verification rather than an established fact. This is particularly important for clinical parameters such as dosing recommendations, contraindications, diagnostic criteria, and outcome measure psychometric properties, where inaccuracies could directly affect patient care. Clinicians should cross-reference AI-generated factual claims against authoritative sources, including peer-reviewed literature, clinical practice guidelines, and professional standards documents. The finding that content accuracy in AI-generated documentation varies depending on the complexity of clinical scenarios reinforces the need for heightened scrutiny when AI is applied to complex clinical situations. This verification habit represents the clinical equivalent of checking a drug reference before administering an unfamiliar medication, a standard practice that reflects professional responsibility rather than technological inadequacy. AI-generated content may also be factually accurate, yet clinically inappropriate for a specific patient, setting, or professional context. A large language model does not have access to the individual patient's medical history, functional status, personal goals, cultural background, or psychosocial circumstances unless the clinician provides this information. Even when context is provided, the model cannot replicate the clinical judgment that comes from direct patient interaction, physical examination findings, and the accumulated pattern recognition that experienced clinicians develop over years of practice. Rehabilitation professionals should evaluate AI outputs against their clinical knowledge of the individual patient, asking whether the recommendations account for relevant comorbidities, align with the patient's functional goals, are feasible within the available treatment setting, and reflect current best practice for the specific patient population. The evidence that only 1% of AI interventions in pediatric rehabilitation were tailored to individually reported participation needs serves as a broader reminder that AI outputs frequently default to generic, rather than individualized recommendations. As detailed in Module 7, algorithmic bias represents a significant equity concern. Clinicians using AI tools should remain vigilant for outputs that may reflect demographic biases, cultural assumptions, or socioeconomic biases embedded in the training data. This vigilance is especially important when AI tools are used to support care for patients from populations that are historically underrepresented in medical research and clinical datasets. Critical evaluation of AI for bias mirrors the broader evidence-based practice skill of assessing the external validity of research findings, determining whether evidence generated in one population or setting can be appropriately applied to the clinician's specific clinical context. As clinicians develop confidence in basic AI interaction, they can adopt more structured approaches that consistently produce higher quality outputs. The most effective AI interactions in rehabilitation contexts follow a structured framing approach that parallels the clinical reasoning process. This approach begins with establishing the clinical context, including the clinician's professional role, clinical setting, and patient population. It continues with defining the specific task, articulating precisely what output is needed and how it will be used. The interaction then specifies quality criteria, stating what standards the output must meet, including evidence requirements, formatting specifications, and scope limitations. Finally, the clinician requests a structured response, indicating the desired organization, length, and level of detail. This approach mirrors the SOAP note structure that rehabilitation professionals already use. The context and task correspond to the subjective and objective components. The quality criteria correspond to the assessment's analytical framework, and the structured response corresponds to the plan specificity requirements. Large language models also produce more consistent and appropriately formatted outputs when the clinician provides examples of the desired result. By sharing an example of a well-written note, a properly formatted home exercise program, or an effectively structured patient education handout, the clinician establishes a reference standard that the AI can use to calibrate its output. This approach is analogous to orienting a new graduate clinician by sharing exemplary documentation from experienced colleagues. The example communicates standards of quality, format, and content more efficiently than abstract instructions alone. Clinicians should be aware that any information shared with AI systems should comply with institutional privacy policies and regulations governing protected health information. One of the most valuable and underappreciated applications of AI tools is their capacity to support systematic thinking about complex clinical problems. Clinicians can use AI to generate comprehensive lists of differential considerations, identify potential factors that may not have been initially considered, explore the implications of different treatment approaches, and stress test clinical reasoning by requesting counter-arguments or alternative perspectives. This application does not ask the AI to make clinical decisions, but rather to serve as a structured thinking partner that helps the clinician ensure thoroughness and consider multiple perspectives. The parallels to interprofessional team discussions are direct. Just as a team conference benefits from multiple disciplinary perspectives, even when the treating clinician retains decision-making authority, AI-assisted thinking benefits from the model's ability to draw on broad patterns, even as the clinician retains clinical judgment. This application is particularly relevant for occupational therapists, given the profession's values of client-centered practice and holistic reasoning. While the foundational principles of effective AI interaction apply across all rehabilitation professions, the specific opportunities, challenges, and optimal entry points differ across physical therapy, occupational therapy, and nursing. Understanding these discipline-specific patterns enables clinicians to identify the AI applications most relevant to their practice. For physical therapists, the documented finding that 63.3% report no AI work experience suggests the profession benefits most from low-risk, high-value entry points that demonstrate practical utility without requiring significant workflow disruption. The most immediately relevant applications include using AI to generate patient education materials for common diagnoses and exercise progressions, drafting initial documentation templates that capture the biomechanical specificity characteristic of physical therapy notes, supporting evidence synthesis for clinical questions about intervention dosing and effectiveness, and creating structured frameworks for outcome measure selection. Given that key predictors of higher AI knowledge include advanced degrees and senior professional status, organizations should leverage these individuals as mentors and champions who can model effective AI use for colleagues. The 33% of physical therapists who specifically identify structured workshops as their preferred training format suggest that hands-on, guided experiences where participants complete clinical tasks with AI assistance under expert guidance may be more effective than didactic presentations for building adoption readiness. For occupational therapists, the evidence that attitudes serve as the key mediating variable for AI adoption has important implications. AI engagement for occupational therapists should emphasize how AI tools support rather than supplant the profession's core values of client-centered, occupation-focused practice. AI applications particularly suited to occupational therapy include generating activity analysis frameworks for adaptive task design, creating individualized patient and caregiver education materials that address functional performance in daily activities, supporting cognitive rehabilitation program design through structured task generation, and drafting justification documentation for assistive technology recommendations. Occupational therapists should approach AI tools with explicit attention to whether the technology supports meaningful participation outcomes rather than purely impairment-based metrics, consistent with the profession's scope. For nurses' relatively higher AI awareness at 73% and positive attitudes at 71% provide a stronger foundation for rapid engagement. The primary challenge lies in translating these favorable attitudes into consistent practical competency, given the variability in AI-related skill implementation at 67%. AI applications particularly relevant to rehabilitation nursing include supporting care, coordination documentation across interdisciplinary teams, generating patient and family education materials for transition planning, assisting with standardized assessment documentation and quality reporting, creating structured shift communication tools that capture rehabilitation-relevant patient information, and supporting the integration of monitoring data from wearable sensors and AI-enabled alert systems into nursing care plans. Nurses' emphasis on employer-supported training during work hours suggests that organizational commitment to protected learning time is essential for converting the profession's attitudinal advantage into practical competency gains. Effective AI engagement requires that rehabilitation professionals maintain the same ethical standards, privacy protections, and professional accountability that govern all other aspects of clinical practice. Regarding patient privacy, when using AI tools for clinical tasks, rehabilitation professionals must ensure that protected health information is not entered into AI systems unless those systems have been specifically authorized by the clinician's institution for clinical use and comply with applicable privacy regulations. Many commercially available large language models are not designed for processing protected health information, and entering patient-identifiable data into these systems may constitute a privacy violation regardless of the clinical utility of the resulting output. Clinicians should use de-identified or hypothetical clinical scenarios when interacting with general-purpose AI tools. Reserve the use of patient-identifiable information for AI systems that have been formally approved by their institution's information technology and compliance departments, and follow institutional policies regarding data sharing with third-party technology platforms. The concern that approximately 90 ambient scribe platforms currently operate with limited regulatory oversight makes institutional governance and individual clinician vigilance essential safeguards. Regarding professional accountability, regardless of the extent to which AI tools contribute to clinical documentation, treatment planning, patient education, or other professional activities, the rehabilitation professional remains fully accountable for the accuracy, appropriateness, and quality of all outputs that bear their professional signature or influence patient care. AI-generated content that is incorporated into a patient's medical record becomes the clinician's professional responsibility upon review and signature, just as a note dictated to a transcriptionist becomes the clinician's responsibility upon review and signature. The competency framework's emphasis on carrying out clinical encounters that integrate diverse sources of information into patient-centered care plans while critically appraising the quality and biases of AI-based tools captures this dual accountability precisely. Clinicians must be both users and evaluators of AI, never passive consumers. Regarding transparent communication with patients, as AI tools become more prevalent in rehabilitation practice, transparent communication with patients about how these technologies are used becomes an ethical imperative. The survey finding that patients with acquired brain injury expressed more hesitancy about AI in healthcare than providers underscores the importance of proactive, honest dialogue. Rehabilitation professionals should be prepared to explain in accessible language when AI tools are being used, how AI-generated content is reviewed and verified by the treating clinician, what data is collected and how it is protected, and the patient's right to ask questions or express preferences about technology use in their care. The journey from AI skepticism to informed practice is not a binary transition, but a developmental continuum that unfolds over time through progressive experience, structured learning, and reflective practice. The evidence reviewed across this course suggests a practical three-phase framework for rehabilitation professionals at any stage of this continuum. Phase 1 is exploration and familiarization. The first phase focuses on building basic familiarity with AI tools through low-stakes, non-clinical applications. Clinicians in this phase might use AI tools for personal tasks such as drafting emails, organizing information, or exploring topics of personal interest to develop comfort with conversational AI interaction. They can then progress to professional but non-clinical applications such as drafting meeting agendas, summarizing professional development articles, or creating presentation outlines. This phase addresses the foundational AI knowledge domain of the competency framework through direct experience rather than didactic instruction. The randomized controlled trial demonstrating that AI-assisted problem-based learning significantly improved knowledge retention at 2 weeks supports the value of experiential learning over passive instruction in building AI competency. Phase 2 is guided clinical application. The second phase introduces AI tools into clinical contexts under structured conditions. Clinicians in this phase begin using AI for clinical support tasks, such as drafting patient education materials, generating documentation templates, and synthesizing evidence on clinical questions. All AI-generated outputs are carefully reviewed and compared against the clinician's independent professional judgment. creating opportunities to develop the critical evaluation skills essential for responsible AI use. Organizations can support this phase by establishing mentorship relationships between AI-experienced clinicians and those developing competency, creating shared repositories of effective interaction strategies for common clinical tasks, and providing protected time for clinicians to experiment with AI tools without production pressure. Phase 3 is integrated and reflective practice. The third phase represents the integration of AI tools as a routine component of professional practice, accompanied by ongoing reflective evaluation of their contribution to clinical quality, efficiency, and patient outcomes. Clinicians in this phase have developed sufficient experience to distinguish when AI tools add value from when they introduce unnecessary complexity, to recognize the types of tasks where AI outputs require more versus less oversight, and to contribute to organizational and professional conversations about appropriate AI governance and best practices. The goal of this phase is not uncritical adoption, but rather the kind of informed, selective, and continuously evaluated technology integration that characterizes expert clinical practice across all domains of rehabilitation. AI technologies will continue to evolve at a pace that exceeds the update cycles of formal educational programs and continuing education courses. Rehabilitation professionals who develop strong foundational skills in critical AI evaluation, effective interaction principles, and ethical technology use will be well positioned to adapt to new tools and capabilities as they emerge. The principles presented in this module, understanding the nature of AI systems, providing structured inputs, evaluating outputs critically, maintaining professional accountability, and protecting patient interests are enduring precisely because they are grounded in the transferable cognitive skills and professional values that define rehabilitation practice rather than in the technical specifications of any particular AI product. Professional associations, educational institutions, and healthcare organizations share the responsibility of supporting ongoing AI literacy through updated competency standards, accessible continuing education opportunities, and organizational cultures that encourage informed experimentation alongside appropriate caution. The finding that only 13.8% of clinicians feel adequately prepared for AI integration represents a challenge that will only be addressed through sustained, coordinated investment in workforce development at individual, organizational, and systemic levels. As we close this course, the conclusion is clear. The integration of artificial intelligence into rehabilitation practice is neither an all-or-nothing proposition nor a distant future concern. It is a gradual, ongoing process that is already transforming clinical workflows, documentation practices, and care delivery models across healthcare. For physical therapists, occupational therapists, and nurses who approach AI with informed skepticism rather than reflexive resistance, these technologies offer meaningful opportunities to enhance clinical efficiency, support evidence-based decision-making, improve patient communication, and extend the reach of rehabilitation services to underserved populations. The evidence synthesized across this course demonstrates that AI tools can produce measurable clinical benefits when appropriately selected, implemented, and monitored, and that the greatest risk to rehabilitation professionals may not be the adoption of imperfect AI tools, but the failure to engage with technologies that their patients, institutions, and healthcare systems are increasingly integrating around them. By grounding AI competency in the evidence-based reasoning, ethical practice, and patient-centered values that already define their professions, rehabilitation clinicians can ensure that artificial intelligence serves as a tool that amplifies their expertise, rather than a technology that diminishes their professional identity. The path from skepticism to informed practice is paved not with technical certifications, but with the same qualities that make excellent rehabilitation clinicians: intellectual curiosity, rigorous evaluation of evidence, commitment to patient welfare, and the willingness to continuously learn and adapt in service of better outcomes. Thank you for completing this course. We hope you leave with not only a stronger evidence base for understanding AI in rehabilitation, but also the practical confidence to engage with these technologies thoughtfully and responsibly in your clinical work. We will now review the exam questions to solidify your understanding. This review will walk through each question, identify the correct answer, and explain the reasoning behind it. Let's begin. Question 1. According to the longitudinal observational study of advanced technology adoption in rehabilitation, which setting accounted for 94% of all advanced technology uses? The correct answer is C, outpatient services. Rationale? This finding reflects the practical realities of rehabilitation service delivery. Outpatient settings are where the majority of ongoing, long-term rehabilitation occurs, and they offer the infrastructure, scheduling flexibility, and patient volume that support the integration of advanced technologies. Inpatient stays tend to be shorter and more focused on acute stabilization, while home-based and community programs often face resource and space limitations that make advanced technology deployment more challenging. As a result, outpatient services naturally become the primary environment where technologies like robotics, virtual reality, and AI-assisted tools are used consistently over time. Question 2. In the network meta-analysis of AI-assisted strategies for musculoskeletal rehabilitation, which intervention ranked highest for functional outcomes with a SUCRA of 99.6%? The correct answer is D, gamified exergaming. Rationale. SUCRA, which stands for Surface Under the Cumulative Ranking Curve, is a statistical measure used in network meta-analyses to rank the probability that a given treatment is the best option. A SUCRA of 99.6% means gamified exergaming had a near certain probability of being the top-ranked intervention for improving functional outcomes. This makes sense clinically because gamified exergaming combines physical exercise with game-based elements that increase patient motivation, engagement, and adherence. The interactive nature of exergaming encourages higher repetitions and more sustained effort during therapy sessions, which are critical drivers of neuroplastic change and functional recovery in musculoskeletal rehabilitation. Question 3. Which variable was identified as one of the most important predictors in machine learning models for post-acute hip fracture rehabilitation, outperforming demographic variables? The correct answer is A, cognitive status as measured by the mini mental state examination. Rationale. Machine learning models are particularly adept at identifying which variables have the greatest predictive power for clinical outcomes. In post-acute hip fracture rehabilitation, cognitive status, pre-fracture functional scores, and admission functional scores emerged as the most influential predictors. This aligns with clinical experience. A patient's cognitive capacity directly affects their ability to follow instructions, engage in goal-directed activity, retain new motor strategies, and participate actively in their rehabilitation program. Demographic variables such as age or body mass index, while relevant, do not capture the patient's actual functional and cognitive readiness for rehabilitation the way these clinical measures do. Question 4. What percentage of physical therapists reported no experience with AI applications at work? The correct answer is B, 63.3%. Rationale. This finding from a cross-sectional study highlights a significant gap between the rapid advancement of AI technology and its actual penetration into everyday clinical physical therapy practice. Nearly 2/3 of physical therapists reported having no hands-on experience with AI in their work settings. The study also revealed that clinicians' knowledge of AI applications specific to rehabilitation was significantly lower than their general awareness of AI as a concept. This suggests that while physical therapists may understand what artificial intelligence is in a broad sense, they have limited exposure to how it is being applied in areas like movement analysis, outcome prediction, or clinical decision support within their own field. Question 5. Which of the following is one of the 6 essential domains in the consensus-driven AI competency framework for rehabilitation professionals? The correct answer is B, social and ethical implications of AI-based tools. Rationale. The consensus-driven competency framework was developed to define what rehabilitation professionals need to know and be able to do in order to responsibly use AI in clinical practice. The 6 domains are basic AI knowledge, social and ethical implications, AI-enhanced clinical encounters, evidence-based evaluation, workflow analysis, and practice-based learning and improvement. The inclusion of social and ethical implications as a core domain reflects the growing recognition that AI tools can introduce issues related to algorithmic bias, patient privacy, informed consent, health equity, and the changing nature of the therapeutic relationship. Rehabilitation professionals do not need to become programmers or hardware technicians, but they must understand how to critically evaluate AI tools and advocate for their patients in an increasingly technology-driven healthcare landscape. Question 6. According to the systematic review and meta-analysis of AI applications in clinical documentation, what was the overall standardized mean difference for reduction in documentation workload and related burnout? The correct answer is C, -0.71. Rationale. a standardized mean difference of negative 0.71, derived from a meta-analysis of 23 studies, indicates a moderate and clinically meaningful reduction in documentation burden when AI tools are applied. In rehabilitation and across healthcare more broadly, documentation is one of the most time-consuming aspects of clinical work and a major contributor to provider burnout. AI-powered documentation tools, such as ambient listening systems and natural language processing for note generation, can reduce the time clinicians spend on paperwork. This allows more time for direct patient care and contributes to improved clinician well-being. The moderate effect size suggests that while AI does not eliminate documentation burden entirely, it provides a meaningful reduction that can positively impact workflow efficiency and job satisfaction. Question 7. What percentage of AI rehabilitation studies incorporated explainability according to the Living Systematic Mapping Review? The correct answer is B, 10.2%. Rationale: explainability, sometimes referred to as interpretability, refers to the ability of an AI system to provide understandable reasons for its outputs and decisions. The finding that only 10.2% of AI rehabilitation studies incorporated explainability reveals a critical transparency gap in the field. For clinicians to trust and appropriately use AI-generated recommendations, they need to understand how the system arrived at its conclusions. Without explainability, AI models function as black boxes, which undermines clinical reasoning, limits the ability to catch errors, and raises ethical concerns about accountability. This gap is particularly important in rehabilitation, where treatment decisions are highly individualized and require clinician judgment to integrate patient preferences, contextual factors, and clinical expertise. Question 8. According to the 2025 Cochrane Review, when virtual reality was added to usual care for stroke rehabilitation, what was the standardized mean difference for upper limb function improvement? The correct answer is C, 0.42. Rationale: a Cochrane Review represents one of the highest levels of evidence synthesis in healthcare research. The finding of a standardized mean difference of 0.42 with a 95% confidence interval of 0.26 to 0.58 indicates a small to moderate positive effect on upper limb function when virtual reality is added to standard stroke rehabilitation. This was reported at moderate certainty of evidence. From a clinical perspective, this supports the use of virtual reality as a valuable adjunct to, rather than a replacement for, conventional therapy. Virtual reality provides immersive, task-specific, and repetitive practice opportunities that promote motor learning and neuroplasticity, which are key principles in upper limb stroke rehabilitation. Question 9. A secondary analysis of a multi-center randomized controlled trial of 190 stroke patients found that age was negatively associated with recovery after conventional rehabilitation, but not after which type of intervention? The correct answer is D, robotic rehabilitation. Rationale: this is a particularly important finding for clinical decision-making. In conventional rehabilitation, older age was independently associated with a worse response to treatment, a finding consistent with the general understanding that aging can slow neuroplastic recovery processes. However, in the robotic rehabilitation group, age was not a significant predictor of outcomes. None of the baseline variables, including age, were significantly associated with response to robotic treatment. This suggests that robotic rehabilitation may help level the playing field for older patients by providing consistent, precise, high-intensity, and repetitive movement practice that does not depend on the patient's ability to generate and sustain voluntary effort to the same degree as conventional therapy. This has important implications for equitable access to effective rehabilitation across the age spectrum. Question 10. For occupational therapists, research indicates that the key mediating variable predicting AI technology adoption intentions is what? The correct answer is A, attitudes toward AI. Rationale: research into technology adoption among occupational therapists found that attitudes function as the primary mediating variable between knowledge, practice experience, and the intention to adopt AI tools. This means that simply increasing a clinician's technical knowledge or giving them more exposure to AI tools is not enough on its own to drive adoption. Instead, both knowledge and practice influence adoption intentions indirectly by first shaping the clinician's attitudes. If an occupational therapist develops a positive attitude toward AI, viewing it as useful, trustworthy, and compatible with their professional values, they are far more likely to adopt it. This finding has direct implications for continuing education and implementation strategies. Training programs should not only teach clinicians about AI, but also actively address concerns, demonstrate clinical value, and foster positive professional attitudes toward these emerging tools. That concludes our exam review. Remember to revisit any areas where you felt less confident and use this review as a guide to reinforce the key concepts tested in your exam. Good luck!